Our next speaker is Dr. Skye Barbic. Barbic is an associate professor at the Department of Occupational Science and Occupational Therapy at the University of British Columbia. She's also the head scientist at Foundry, which is a network of 16 integrated research centers across British Columbia, with 19 more centers on the way. Am I getting the numbers right? It's hard to follow because they keep opening centers. It's such an amazingly dynamic organization. Dr. Barbic is an active member of the Health Outcomes Research Community and was awarded the top New Investigator Award at the International Society of Quality of Life Research Congress for her work on the application of modern measurement methods to understanding depression. She also serves on various advisory roles to the Canadian government, including on the Council of Mental Health that provides advice to Canada's Ministry of Health on how to improve the mental well-being of Canadians, for which we are very grateful. I've been very fortunate to collaborate with Dr. Barbic over the last few years, and I just keep learning so much from everything you say. So I'm sure I'll learn much more from this talk. The amazing data is who will cross the line first in healthcare. Please join me in welcoming Dr. Barbic.
First things first, those of you who are online, I didn't mean to match the wall in the back, so just a giant head moving on your screen. I apologize. I will try to move and be active so that I don't disappear. So really grateful for the mentorship and collegiality of Dr. Tell and Sebastian, being able to work with you for the last. We had this great project, and it's going to finish soon, right? This project's going to finish soon, I hope, and it's on me. I know I'm taking it, but I do. I got up every Friday morning at 6:30 to have this conversation about data ethics and mental health with Sebastian, Darius, Aran, and others. And it was really like the best part of my COVID experience by far. Like, we did it all through COVID, and if my family hated it because I have a small house and I woke them all up in the morning talking about data ethics. I laughed, I cried on the calls often because we say, like, here's this optimal experience, here's this great optimal thing we want to think about. But the reality is we're in this race, and it's hard, and the healthcare work is hard, and change management is hard. And so these are some reflections from that work, but with a lot of gratitude from this team, but then also the gratitude from folks like Dr. Henderson and Dr. Matthias who are out there and were like, yeah, let's just, all these walls are up there and they're in the way, let's just blow them up. And so someone who's early mid-career researcher, like, not a good thing to do, don't close up walls and doesn't care. And we come behind and pave the streets after things have been destroyed, and the good things that need to go are going away. So these are a lot of thoughts that are coming from this group and from my team at home on the unceded ancestral territory of the Coast Salish people. I've been thinking a lot. I've never actually seen those retro Olympic rings on the building that we're looking out over, but I really just want to ground myself that I am home. This is where I grew up. This is where I did my PhD. I had my son up the road at the Royal Victoria Hospital. He was probably one of the last babies born there before it closed. And I also knew nothing about the territory in which I lived on when I was here. I went to postdoctoral studies, and it was really the first time when I went to the Center for Addictions and Mental Health, I started to learn about the history of the land in which we worked and played and lived on. And I was really a postgraduate student at the point where I started to learn with my kids and with my family about the work about the lands that we lived on. I really knew nothing about this. So it's incredibly, with deep respect, that I've been looking at over here and just thinking about what this land and territory would be about 700-800 years ago, before settlers came in, and what in a remarkable space this river meets the lands and the mountain. I can't call this a mountain. My husband says it's a hill, but also that now I'm on the other side of the country, and most of the work that we do happens on the unceded ancestral territory of the Squamish, Tsleil-Waututh, and Musqueam territories. And so with that, I'm going to introduce myself in Squamish. Those are the territories that I live on. So Hatswell Tanoya, Skye Barbic, Keenan Sna. Good morning, my name is Skye Barbic, and I use she, her pronouns. And I'm going to talk to you today about the things I love most, measurement and mental health. I thought I had no measurement or interest to declare, and then you put yours, and I was like, obviously I do, so I have funding from CIHR and people who fund me to do this work, which is exciting. So what I want to talk to you today is about what is this concept of the data race. I want to talk about the opportunities for mental health, next steps in application, and calls to action. And this is a cartoon just that will come out throughout about, what we have in this typical patient experience. We've given a questionnaire, and the way I feel is hard to quantify. Well, how hard is it to quantify? It's 1 to 10. And we get this, and really the idea that all these big dreams, aspirations, ways that we feel are just boiled down to a scale of 1 to 10. I tried to use the 1 to 8 example, or the 8 one time, and I realized it totally was your example, and it was Colombian, and you're gonna go with that one. But this is my favorite cartoon of Calvin and Hobbes. And sometimes the work that we do in mental health, especially lately, feels like we're racing down the hill and we have no brakes and we're wishing for the best. But really, I'm going to start off with the takeaway message. Absolutely love watching this, and it's fun, and so we were watching this, but I thought this is exactly sort of what we're doing in mental health, and I'll tell you a little bit what that means in a second. But the takeaway message for today is that if we are actually going to create an impactful transformation in our mental health system, this is going to require an aligned approach with a clear measurement and data strategy that is person and community centered and considers the long game. So we can't do this in 2 or 3 years, and it considers equity. And if we do this well, it's going to be value added, ethical, and inclusive. If we do it in a mediocre way, it's going to be expensive and pretty wasteful. And if we do it poorly, it's going to be dangerous. So the motivation for this talk, Sebastian, I'm not sure if it's you that shared this cartoon with me one time. Was it you? I was trying to remember who shared this cartoon, but it did remind me of when I was in high school. I had this awesome physics teacher, and he got up on a chair, and I won't do this because these ones have wheels, and he got up and sorry, I said high school, first year university. This is when I was in university, and I got up on a chair, and he's like, the unit of measurement matters. And he used this example because this very expensive mission to Mars, they went to Mars, they spent billions of dollars getting this thing to Mars, and the bloody thing crashed straight into the ground. And the reason it crashed is that one person did the calculations in meters to the ground, the other one did the calculation in feet to the ground, and this basic concept of the unit of measurement blew up this billion-dollar exercise. And so this was really important to think about measurement being critical. And you think, how stupid could this be that they invest, they get so far down the road in building this exercise and planning everything and every possible thing that could go wrong, except for they didn't look at the unit of measurement. Fast forward to early 2000s when I became an occupational therapist. This is the front entrance of the old Kingston Psychiatric Hospital, now called Providence Healthcare. And I ironically work at another Providence Healthcare now in Vancouver, but this was the first PHC building that I worked at. This was the entrance to the inpatient psychiatry unit onto Ward 13. And I started working here for a couple of years, and the folks who I worked with had been hospitalized for up to 30 to 40 years. They'd spent their entire adult lives on this locked unit. And shortly into my tenure at that visit, I was asked by the hospital organization to lead up a specialty team called the Super Community High Intensity Treatment Team, the CHIT team. It's great, didn't name it. And it still exists, the CHIT team, I believe in art in Kingston. And this team was really brought together to take a 400-bed hospital, and they were cutting 350 beds. And they were going to put 350 people in the community in Kingston, Ontario, who had never lived in the community in their lives and been hospitalized for most of their adult lives. And they did this because this is what the government said we're going to do. They decided we're going to move these folks out and close this hospital. It was too expensive. And so we went to start reading the charts and started to really change the dialogue of the conversation of how do we make your day, go by somewhat meaningfully on a locked unit, to what are your goals? What are your dreams? What does living in the community look like to you? What do we need to actually support that to happen? And for people who have been so institutionalized in this mental health system, they're like, I don't know what my goals are. I have no clue. Like, I need to take my meds on time. I need to I need to get to my doctor's appointments. These are the goals. This is what people are worried about. They weren't worried about having a house, a home, and this is a very big turning point in mental health care, where we shifted from this idea of institutionalization in mental health towards people living in the community. And it was also fast forward from that, not too far forward to about 2005, where it started in the research community. It was interesting. So all of a sudden mental health was behind, and we were talking about person-centered care. All of a sudden we were talking about making environments more accessible. But the FDA was doing some interesting work in the patient-reported outcomes work as well. And they started to see a lot of drug labeling trials coming across for approval. And they started to look at how they were measuring the outcomes. And they were saying, oh, it's interesting, you're measuring outcomes that are important to patients. Well, how are you measuring them? And like, oh, we're measuring with this generic measure designed by 4 white guys without the health condition. Okay, maybe you shouldn't do that. Maybe you should go talk to the patients who you're studying with. And so they stopped, they actually stopped approving drug trial and said, Dr. Towles, you're studying 40-year-old men with pancreatic cancer, go talk to them about quality of life, ask them what quality of life means to them. Don't just use the same tools that were designed for some research metric of X, Y, and Z that has nothing to do with what you're actually studying. And then, so anything, outcomes are important, talking to patients is important. This is a big shift, this is big. I think I just saw an article in, I think it was Lancet in the last couple of days that said, talking to patients, patient-centered care is one of the most revolutionary top 10 things that's happened in medicine in the last decade. So that's a pretty big step. Like this seems so logical to us now, right? But then we have this sort of incident, I don't want to call it an incident, a moment in time, which has been really interesting about how our Canadian research community responded to this, where large organizations such as the Wellcome Trust and Lancet came together, and they thought, you know, it's really hard to measure the things that we measure in our research, and people measure with a whole bunch of different tools. And so why don't we tell the researchers, if you're going to study depression, this is the measurement tool that you have to put into your clinical trial, and you can't get published in Lancet unless you use these specific measures. And that was pretty interesting because the idea was good. The idea is comparing apples with apples and using the same systematic tools and trying to study the same thing. But what they didn't talk about was how these measures were designed in the first place, and were people with lived and living experience ever involved in the co-design of those measures, and what did that actually mean for us in terms of research, that were we using the best actual precise tools. And so we were at a conference in Copenhagen when this was all sort of rolling out. And one of the interesting things was that our Canadian Health Institute of Research, NIH, very much supported this in the US, this strategy. But our Canadian Institute of Health Research reached out to researchers like Dr. Tal and Dr. Henderson and said, is this a good idea? Like, do we have the best measures to measure outcome in mental health? Like, should we prescribe to this way and only approve CIHR funding that actually has these measures? Should we give the researchers the tools that they should put in their grants? And overwhelmingly, everyone said no. And overwhelmingly, everyone said, Dr. Tal said no. because what Dr. Tal made us think about and Sebastian made us think about is like, but why the heck are we measuring in the first place? How are these tools designed in the first place? And why does data matter? And what are we going to actually do with these data? And how are we going to mobilize it in a good way? And so CIHR really listened. And then fast forward to this last year, this was a lot of action that was happening at our health ministers meeting. It was held in Vancouver. And what they couldn't agree on anything, like in that meeting, basically they left. And one of the reasons why they couldn't agree on anything was the federal minister of health, Minister Duclos at the time, said for the first time, we're not going to transfer money to the provinces unless you show us some accountability that you've used that transfer payment in a good way. So if we transfer $10 billion to your province for mental health, we want to see that it actually happened. And so you're like, from the Netherlands, this has been happening with you guys for decades. This has never happened. So I couldn't get connected to the internet. I was looking for the confetti party picture because this is really what happens. And so Tommy Douglas, who said institutionalized this provincial and territorial jurisdiction health system that we have in Canada, where health is a jurisdiction of the province or the territory, and the feds would just sort of transfer money and then you decide what happens. And that's a really big trust, and especially for things like mental health, where no one was feeding any money back. Sometimes provinces decide, actually, today's seniors is what we should do. And so mental health just kept getting pushed off with no accountability of data to say, here's where we're at, here's where we're going, here's how we're going to get here. And so this was a big change. The interesting thing that the only thing that these ministers agreed on in that meeting, correct me if I'm wrong, is that youth mental health was important. And so that's the only thing they agreed on. And they didn't want to show data, but they ended up signing because they realized they had to do it, they had to actually show some kind of accountability of their transfer payments. So that all sounds good. We like imagine this beautiful system where the federal government transfers funds over to the provinces, and then they do this beautiful thing. They measure data over time. We have measurement-based care. They feed data back to the provinces. They can see that beautiful map that you showed, that heat map of where they should invest. And that all sounds really good. Hypothetically, and you just brought up the Netherlands example, hypothetically, you hope they bounce the wall and it just goes in the right direction. But really for the last 2 decades, it's felt like you have all these great ideas and then you throw the ball against the wall and it just flops. It just flops consistently. Or you got it bouncing and then a new government changes. And it's so reliant on all these things that just are beyond your control. And this is maybe where my physics teacher comes back into place. The physics matters in this situation. And so what is this Amazing Race concept? And if you haven't watched the show, The Amazing Race is this popular reality TV show. There are teams racing around the world for a competition for a cash prize, and it's known for fast-paced, adventurous format, which combines elements of travel, physical challenges, mental puzzles, and teamwork. Stole that from their website. So what's the amazing data race in health and in mental health? And this, I really could argue, is a popular exercise in health services research right now that features teams from across the world trying to find the best way to measure outcomes, often for a cash prize. They put the cash prize there because if you design the best tool out there, it often is sold for quite an extensive amount of money to pharmaceutical industries who want to use the best tools, of course, because they want to use, the FDA told them they got to go use the best tools that are fit for purpose for their patients. But that often comes at a point of ruination for the researchers in this case. The race is also known for fast-paced and adventurous formats. Our outcomes are changing all the time. There's people working from across the world to try to figure out what to measure, how to measure. But it's also known for limited engagement and poor experiences of patients and of providers. And so we have this sense of, I developed the best tool, and then you forget that you have to teach a whole bunch of clinicians how to use the tool. Or you forget you have to actually collect the data for the patient so that they can mobilize their care plan in a good way, versus why do we just collect the best tool for the FDA, the best tool for the government to have data. And so really thinking about the rush in trying to get the best data has been also something that's come at the expense, as Dr. Henderson highlighted this morning, of not thinking about what the vision and the values and the principles are of doing the work that we do, and how do we slow down a little bit in this race and think about it more as a marathon versus a sprint to get to the end. So what is this opportunity for mental health? I think the analogy I want to use before we go down this list of death by PowerPoint, but I didn't know how else to present this. The analogy that I wanted to use was the cell phone and social smartphones. And there are many developing countries in the world that we're in the global health space, so I thought this was an appropriate example, and I think I learned this example here, is that they skipped the telephone wires and telephone altogether. And they went from having no communication to smartphone technologies. So many countries in Africa never put up telephone poles and wires and all the system and infrastructure. They went right to this. And I think in mental health, we're so far behind in so many spaces when it comes to health outcomes and it comes to measurement-based care. But we have this opportunity to just jump ahead. And we don't need to think about all these processes that have been in place for 2 decades. I think we can get to a point of absolute new innovation, leverage things like AI, leverage things that are really grounded in innovations, such as, it sounds so silly, but the values and the principle work is so innovative in mental health. We've never done that the way that Dr. Henderson described it. So I think our opportunity for investing in mental health is that we need to stop and talk to the people that we're working with and ask them what's important to them, and just stop for there. And I think this might take us decades again, or maybe not, but what are we actually measuring? Are we missing the target entirely? And I think when you actually talk to people, I've never had a patient come into my practice and say something's broken in my brain. I think they would be stoked actually to see the MRI though, and see that something's broken in their brain. And no one's ever walked in and said something's broken in my brain and I'm chemically imbalanced, help me. They say, I'm struggling at school. I'm struggling at work. My family doesn't get me. I'm just I just can't get out of bed in the morning. And so the things that we're measuring about the broken brain, that's important, potentially is important, but we're not measuring what's important to that person, how that person's functioning in the community. And yet we target only the broken brain often. Our mental health services are not targeted where that person's at, and we often only target the services when they're in crisis. So we don't think about what does health mean as a full construct of going from low to high. In mental health, we invest about 97% of our entire healthcare budget in the crisis zone. So we support people who are in crisis. We don't invest in health promotion, early intervention, prevention. So let's first understand our needs. What are we actually trying to do? How do we conceptualize these constructs? And so the Quality of Life world does this really well in spaces like cancer and rheumatology, where they work with patients and they develop these constructs as measurement constructs that go from low to high. What does it mean to have the worst possible quality of life? What does it mean to have the best quality of life if you're a 30-year-old patient with rheumatoid arthritis? And they systematically build out these conceptualizations of these constructs. And a lot of the great work happens at the, what's it called, the Outcomes Arrest Lab. It's up on the road, up on the mountain here, which is great. Or they're not up on the mountain anymore, they've moved. I'm sorry, we used to be up in the tower on the mountain, not there anymore. They got moved out by the bats that were in the Royal Victoria Hospital. So that was a fun way to do your PhD with bats. It motivates you to get out quick, that's for sure. Yeah, so conceptualization, what's important now? Let's conceptualize these outcomes. Let's work to actually measure them, to find out how we measure them, developing items in a systematic way. So most of the tools that we develop, and we have to call this out, are not designed for the people that we actually work with. They were designed and fit for purpose to tell you an endpoint clinical trial change in some drug label that was approved, or some intervention that was trying to get approved. And so what they were looking for is developing tools that show that 0.5 standard deviation difference, right? They weren't showing tools that would guide clinical care, measurement-based care. They weren't developing tools to empower folks. They weren't developing tools that were considering the needs of diverse people, because you develop a tool that's homogeneous, right? You get a homogeneous group of people, so you have no diversity and your validity is super excellent. So you don't consider external validity. And this is really the reality of the situation. So now we're being told by folks like Lancet and NIH to use these tools that were never designed for the actual work that we're doing on the ground. So what if we conceptualize the outcomes, we built these instruments that are actually fit for purpose, and that we had a system to continuously improve these instruments over time? I'm going to talk about a little bit, feeding off Dr. Hennis's work, is we have this opportunity in mental health now because we're actually connected in this learning health system structure to do that. We're not just collecting data in one little lab and hoping for the best. We have this opportunity for shared data infrastructure to not only get better at the instruments that we develop, but also to mobilize the data in real time to the people who need to use it. So you just saw this map. So this is where I'm coming from in terms of perspective, but this is really new in terms of growth. Like Waihu's much, what are you at now, 35?
Yeah.
You were like 3 yesterday.
No, we got a lot.
Yeah,
We have doors open at 31.
31, which is pretty, like, this is really multiplying. And there's a lot of investment in this idea that if you provide good care to young people early, that this will work. And there's a lot of excitement in Canada, but our partners in Australia, who are about 10 years ahead of us, will tell you it's all fun and games until people start saying, yeah, but how cost effective is it? You know, are you really showing change? Like, what's actually happening? And so the nice part is that we're able to work together and be mentored by our folks who are across the world, seeing what they're being challenged with right now to move forward. So hypothetically, what if, in a way where there's no, you have to, like, for those of you who are from Canada, this is right for you, there is absolutely no motivation for provinces to work together in the government of Canada. There's no motivation for us in health. There's never an incentive because everything is provincial or jurisdictional. And so that's why we have these very siloed, pretty much 13 countries working together under this jurisdiction of Canada. But what if we actually all worked together and said, what's important to young people in Canada? Or what's important to people accessing mental health services in general in Canada? What if we had the infrastructure to do item development and testing in real time? And what if we had this national training system actually train people in measurement-based care and implementation? And what Joe described as the national data through Brain Canada and Health Canada, what if we just, this wasn't like, you know, a data set where you collect data and it gets funneled. Often that's what happens is data gets collected, it gets funneled, it gets stuck, and there's no strategy to move it, to analyze it, to use it. And it just sometimes gets accessed by some junior policy analysts in government who's deciding on some decisions about funding. But what if we actually felt that youth were underpinning this? This was data that was driven by youth. We were measuring the outcomes that were important to youth. We were using tools that were scientifically robust. And then we were training and empowering clinicians across the country systematically to deliver this using measurement-based care. And that would be the dream. And then the dream would be that then the things that come out are standards. For example, how do you develop standards for accessing youth mental health? How do you access standards that you show up to an emergency department right now and within 24 hours you're connected to the most incredibly person-centered care service that's going to help you throughout your mental health journey? Or you show up to your emergency department, they're like, you're not at risk of hurting yourself or others tonight, so goodbye. And then you show up the next night, and then you show up the next night, and there's no system of care that you get built into because there's no standard for that. But it's also going to help us build this evidence base that's really meaningful and driven by the values of young people or by folks who have lived and lived experience of mental illness. It's going to help us actually be more accountable to our funders and help funders make decisions about where to invest. And it's going to be this national quality improvement exercise. And I think truly, virtual care, not virtual care, app-based services are probably the best example. About 96% of apps that are developed die within 2 weeks. So imagine the research and the funding that goes into this app development, and they die within 2 weeks because there's no buy-in from the end users, and there's no long-term plan about how they're going to get used, and there's no quality improvement efforts. It's often the quality improvement piece that makes the apps die. So it works like it should. That's a dream. This is my national data plan. I hope it works, but it's not going to stick to the wall unless we do this. And so Joe did talk about this. I thought maybe I could just layer an example on yours if that works, about this learning health systems concept, because I really truly think the approach that just talked about was still very top down. This is going to help empower our communities to really move forward in a good way. So this is a definition of learning health systems from our colleague Matt Manier up in Quebec City, where science, informatics, incentives, and culture are aligned for continuous improvement and innovation, and where best practice seamlessly embedded in the delivery process, and new knowledge is captured as an integral byproduct of the delivery experience. So we're not collecting data to collect data. And so sometimes we have this new scale up of an intervention we're working on the West Coast right now. And the first thing that the team says, well, just let's collect data and see how it goes. And no, that's absolutely not where we're going to collect data. We're going to collect data. But before we do, we need a complete strategy about how we're going to use it. So what we've boiled down, CIHR has helped, and Joe's done this very complex article into these 3 components of practice to data, data to practice, data to knowledge, knowledge to practice. And I'll go through this with a bit of an example. But the idea is that you would start up with an idea at the top. So walk-in counseling is a very common service that's offered in both adult and youth mental health services. And the question might be, what does success look like in walk-in counseling? How do we know what data do we need to collect? How do we know it's working? And that's really that practice to data section where you're developing your data strategy and your measurement strategy. What outcomes are important to our patients? What tools do we need to use? Who do we need to bring in at this point if we don't have the right tools? And this is where this beautiful coalition and lots of planning could happen with service providers, with patients, with measurement experts, with ethicists. We can have a whole bunch of exciting folks here, and I'll show you that in the next slide. The next part with data and knowledge is, okay, so we have the data, we know what's happening. This intervention walk-in counseling may or may not be working, or may be working really well for some people, but not for others. And this is where you get into the quality improvement work, and you start to actually tailor the intervention, learn from the data to get better at the quality improvement aspect. And the knowledge to practice piece is where we sometimes rush to and like, it's the best. Mindfulness is the best, go for it. And this is an example I use for mindfulness because now we're learning that mindfulness is actually quite harmful, especially for young people who are in schools and delivering. And we all thought mindfulness was really, really good. And now we're learning that there's some things we need to consider because it doesn't work for some populations, and indeed is quite harmful. And so we need to think about some things. And so this is a part where we sort of scaled up a lot of mindfulness programs across schools, but now we could go back to the practice of data thing and think about what's actually happening there. So just breaking it down as an example, so the practice of data, what would be the impact of scaling walk-in counseling to improve the outcomes? You could say, what's the role of research, evaluation, quality improvement, engagement, clinical services policy at this time? And then you get in and you'd be like, oh, okay, it only works, it works super, super well, but it doesn't work in communities A, B, C, and D, or A, D, and F, and they all just happen to be rural communities. So what's going on in those rural, small communities? Let's get in there and ask questions and work with them to get better. And then also maybe that doesn't work for folks who are non-binary. And so that's great. Everyone's super, super happy, but the non-binary folks are not happy with the experience. What's going on? Let's actually get in there and do the work. And then this is when you figure out that it's working, that you don't just share it with your mom in a publication and like, hey, look, I got published. That we have this national network to share knowledge with. And so this is the work that Dr. Henderson and Matthias are leading to bring together all of these organizations across, not just as people providing really good services, but as learning entities where we learn from each other and we share data in a really good way. So this is really exciting and I think can be totally applied to anyone in mental health right now, because we have models like assertive community treatment teams and in the adult space. There's this easy things, what we need is this national coordination of the provinces and territories to come together. So because this is a workshop, that's just an example of peer support as a program that we're scaling right now. And we're starting with this top end of what's the extent to which peer support improves outcomes for youth 12 to 24. And this was a fairly well-funded program. And we could have said, thank you for the dollars and that's it. We could have just gone and run the program. But instead we have this very sophisticated strategy that's building up, and we're doing it in consultation with other people who are providing peer support, and our colleague Gina in Alberta. We didn't even know she had a call about peer support for a project she had. She expected 5 people on the call and over 150 people showed up on the call. Like, they were really interested in peer support. So who's actually in the research network? How do we bring them in early? And then we can learn about some different things in quality improvement and then scale the knowledge across the network. So maybe what we do in BC doesn't work in Nova Scotia or New Brunswick, and that's okay, but we want to just keep on feeding the knowledge into some cycle. So I think this is an exciting space for us to skip telephone poles and move right into this really applied space. And I think people like Dan talking about just everything in terms of the ethical considerations, the technological considerations, we can jump leaps and bounds ahead of where we have been standing in the general health space for a long time. So just next steps in application and a couple of calls to action. We need a systematic accruement of data in health services in general, and we need it to be fit for purpose. Yeah, no problem. Joe talked about this. We need systematic engagement. And I'm gonna skip to my favorite part of, and Joe talked about also that can't be boring. You can't do anything that's boring with young people if you work with this. This is like the most cited paper I have right now, and it's like interesting, but it's just the title that's sexy. And so this is something I think I probably could talk about all day long. But if you actually measure what's important to young people and you understand what's going through in terms of the items that capture these outcomes, we can also then talk about how we fund these outcomes and fund the right places. And I think right now we're funding all that hot red area, but folks who are in crisis, and we're not actually funding the full range of services. So my last 3 calls to action are on, and then I'm out of here, I promise. We need a national, I was doing this pretending that somebody really important with a lot of dollars was in the room, and I never make the assumption that they're not in the room. But we do need a long-term investment in this, and we need to understand what are the outcomes that are important to measure, and we need an outcome measurement strategy. And it's very hard to get funding and measurement, as we all know in this room. It's very, very hard. And then we need this ongoing investment in our learning health system that prioritizes both youth engagement or engagement in general and measurement excellence. And I would add ethics excellence to that as well, like really learning about the history of the work that we've done so far and how do we actually get better and move forward in a much stronger way. And the last one is really, we need to have this call to action for folks to invest in learning health systems. And this is the first time it's ever happened, thanks to Joe and Steve, our colleague Vidya, who's not here, but really having CIHR, Health Canada, and various ministries across the provinces come together to say, yeah, this is actually important, we're gonna take a chance on you. So if we are gonna take a chance on you, and we're gonna get to this amazing race, we need to make sure that we're doing it and we're providing value added, it's ethical, and it's inclusive. We're not gonna be wasting money, and we're not going to be thinking about dangerous, because people should not be ever hospitalized for 30 years because they have a mental illness. We need to think about what their goals, dreams, and aspirations are. This is the last slide of a quote from our colleague, Dr. Sam Weiss, who is the director of CIHR's Institute of Neurosciences, Mental Health and Addictions. And this is basically summarizing the work that's happened in the 13 provinces. And I'm just going to read the second half of the quote, that if we're going to transform access to evidence-based integrated services for all youth in Canada, the goal is that when completed, not a single youth between the ages of 12 to 25 will be left out without access to health and social services. Youth will determine their own healthy future by being at the center of it. Thank you.
much, Dr. Barbic, for this very inspiring talk. We have about 10 minutes for questions. Floor is open. Also gonna see if there's anyone online that is.
I have a question, like, what's your understanding for why researchers have been more focused on measures like that's more about, let's say, like brain imaging rather than like a functioning based measure? Like, is it because these are more like sexy measures, like that they found could be interesting, whereas like the functioning based approach, well, that could be more relevant for patients, but it could be harder to publish? I mean, I don't know, I'm just giving out like possibilities for why there had been this so much focus on these more like other kinds of measures rather than a functioning based approach.
So I don't know if Dan, you were leading that study, but I was really devastated when those results came out and you asked young people, like, did you prefer patient-reported outcomes, the clinical service interaction, or the FMR, like they got pictures of their brain in that study. Was that the same study you were talking about? Joe, I know you had talked to me about this study. The summary is they liked the brain imaging and they hated the patient-reported outcome questionnaires. And so I think we just haven't, but yet the example that Joe gave about diabetes, and like, I'm a person with rheumatoid arthritis, I've been given patient-reported outcome questionnaires for my whole experience of that condition. I never question it, it's just part of the flow, it's explained in a very different way. And so we often just give questionnaires and the metaphor of putting them on a box. They're subjective, they're sort of viewed as, yeah, we did it because someone told us to do it, versus you're filling this information because I value that going to school is really important to you. And I need to understand what's getting in the way of you going to school every day or going to work or being a parent or whatever your roles are. And it changes the narrative of I'm just not here to fix your broken brain. Like I know there's an intersectionality of the things that matter to you. And you can't collect that data in an fMRI. You can't, like, you can see, a hole in the brain, or you can see some certain action, but you don't know that there were 4 generations of trauma that came before you, or you don't know that there was this really critical thing that's so important in your life that has to be part of like your kids or whatever it is. And so we tend, I think, just as a historical exercise of being in a very biomedical model where we focus on the biomedical outcomes. We fund the biomedical outcomes, we fund the research that goes along that, and we don't often function the functional parts of like, this is actually what matters. And it's more of a philosophical conversation. What do we value as a society? Do we value really fancy hospitals, or do we value people participating in society? And this is where like the Netherlands and a lot of the Scandinavian countries have shifted towards a much more focus on early intervention prevention efforts, and they're showing really positive outcomes. It just takes a big risk and a big shift in philosophy and governments to come together and say, we're going to invest in these things that matter, and you have to ask the people what matters to them first. And that's what especially Finland did. There it is.
A general theme in like the learning health system is like finding strategies to overcome some of the friction and going from like data to knowledge to practice. So you mentioned like it can't be boring, like that's one friction for acquiring the data. And I was thinking of another one in terms of like once the evidence comes in for certain practices, then like feeding that back into practice and saying like, well, this thing, mindfulness example in schools actually didn't work for a lot of people. But then for the practitioners who are used to doing that kind of thing, how to go about changing their trajectory in terms of their practices, which might be kind of ingrained. Like I was reading on like history of oncology recently, and there's some like crazy examples of this kind of friction. Yeah.
It's such a friction, and like I guess COVID taught us that we can't all mobilize and do things quickly if it comes from like let's we saw that as a public health response. And then I live in a province, and I now understand that Quebec is experiencing a lot more of the overdose crisis here. Like we're 8 years ahead of you guys. We have so much learning, and no one's asking Quebec. No one in Quebec is asking what's going on in BC, like, and there's just this shared like concept that we have to, we're always in, because we are actually always in crisis on our own. Like we're always in this data crisis or this health systems crisis, versus thinking about this long-term perspective and the tension. And I think it is going to take strong top-down leadership to say, from your medical schools, we're teaching you about measurement-based care. Imagine every medical school across Canada taught their physicians measurement-based care. And I'm gonna ask if that's happening. Is it happening at yours?
Don't ask.
Don't ask,
Yeah.
okay.
For first 1.5 years, I was traumatized the way they were teaching research and stuff that it just.
It is,
Seriously?
I've heard that
That's
from a
what you
lot
guys
of,
are teaching?
MD, PhD students, all that say that, they're focused so much on your blood glucose levels and measuring
We-
that and the weight of your patients versus.
8 decimal
actually-
matters to us, that's it.
Yeah, so you don't learn about actually how do you talk to your patient, what their goals and dreams and aspirations are. So there's this tension, and I think it's gonna take a top-down approach for sure to address this. But also it's gonna take our research community much stronger, that don't just get your research out and don't build in any implementation, and don't build implementation only at the city level. Like, we gotta get into all of our communities and talk to them and empower them to use the data in a good way and to share their success stories.
We have a question from Susan. By the way, Susan, you're also welcome to unmute yourself. We do have a speaker here that we haven't tested, but I'm gonna read your question out loud. She's saying, for too long, we have handed questionnaires to patients that didn't ask about what mattered to them. We have a lot of work to do to convince patients that new prompts that we co-create with them can make a difference. So it's more a statement than a question, but do you want to respond to that?
There's an exclamation mark at the end of it. I think that's, those you don't know, Dr. Bartlett was my PhD supervisor. So, always, I've learned so much about this, especially from Dr. Bartlett and the field of rheumatology. And watching the concept of just handing patients these papers and not using them and never knowing your data goes is, it's just, look, we gotta stop. We just have to stop it. And I think we have to do it collectively, just make a commitment to say no more, but we're gonna do this. But we can't just tell people to stop. We have to give them the tools, better technology, better infrastructure to look at their data. And I think this is actually bringing the app back. I think this is where people's smartphones and app-based technology, where they have their files and on their phone, they can see their own health information and make decisions. That's the cool opportunity here.
So I actually have a follow-up question to that, which is so I'm very much in favor of the concept of a learning health system, but I also have the worry, and you'll hear more about it in my own talk, that it's bringing back this need for very rigid, uniform measures in order to have comparability across people, across time, across different communities, maybe across countries. And do you see that as, first of all, do you notice this kind of push in relation to learning health systems, and if so, do you think it's in tension with the need for kind of more personalized, community-specific, even age-specific, region-specific measures?
So this is where I think technology and modern measurement are gonna help us a lot, and we have to invest in that, but that's a whole other talk for another day. Because you look at fields like education that give kids different tests in different countries, and we still compare countries and schools across time, and the outcomes that they measure are not directly observable. So like math ability, reading ability, you can't take an MRI for, and Dan can't say, oh, that kid's the smartest, They take these math tests, and we develop these tests, and then we develop ways to compare. So there's science is there, and I think that's really exciting. The technology is there. And I think if we ever get into your question was really brilliant for Dr. Henderson, and I think that's the takeaway. If we ever get to the point where we're just using the same test over and over and over again, we're back to telephone poles and building telephone poles of communities. I think we have to start thinking about how do we use things like computer adaptive testing, and how do we build the infrastructure so someone's always looking at, that doesn't work. Like, that does not work in a rural community in northern Quebec. Like, that question translated doesn't work. What are we getting? This doesn't make, let's get in there and do the work to get better. But it is going to take infrastructure and some support for us to get and work with communities. We've never done that, or we just work with the urban communities and we never think about the smaller communities, and we wonder why it doesn't work for them. So I think it's going to take a lot of unpinning the way that we do things, but we have the technology, we have the science. This is where the researchers become really critical. And we have the patient voice, I think, is the most important thing, that they're saying, we don't want this crappy care. We want really, like, youth are really able to articulate their needs very clearly now. And then if they don't like you, they tell you on social media very quickly. So we have to get better, and we're not only going to be getting slammed for not being cost effective from government, we'll be getting slammed in the media for X, Y, and Z. So I think if we listen to youth, we'll be guided, or listen to patients in general, we'll be guided in a really good way. I know I'm holding you between lunch, I'm sorry.
Yeah, Femke, last question from Femke.
Tiny follow-up. I don't actually have questions because I love basically everything you say. So it was a surprise to me to not have questions. But I would like to emphasize something, being based in the Netherlands and having done a lot of work on this where I'm super critical. I think the one thing in your talk that really stands out to me and maybe should get a bit of more stage when you reach out is that the innovative part, I think here, is that you really emphasize to look into where it doesn't work. Because the emphasis is so often on where it does work and where the good outcomes are, and we measure that. And like I said before, then it might become like normative. It may reify into some sort of a model of how it should go. And then the people that don't like fit in there, they fall out. And I think what I hear in your talk a lot is like, if we have this learning system that's more dynamic, but it's also open to like therapists saying, there is this case here that doesn't work. And we collect data on those people, and then like from a bottom-up perspective, we build some knowledge base on like what to do if it doesn't fit. I think that's the most important part for like an inclusive evidence base.
Yeah, I think that's where you need the people with power, like Joey, you called it like flat out, like I can't do things, I can't say no to a lot of things because I'm a mid-career researcher, right? I can stay in my lane, be really polite for like a little bit longer. But Joe saying no, like actually no, and I've watched you say no so many times, I'm like, wow, you did it again, like you said no, and and we're not to like be like not right, but we're not gonna run a study with 200 very white people of all the same origin. Like, no, we're not gonna do that. We're gonna think more inclusively. We're gonna think about the processes, and then I like you often like have that specificity of who's in the room today, but who's not here. And so whose voices do we not bring in, and you always bring that into the room. And so I think the specificity of thinking about that, it will be longer, it will be probably more time consuming. And I'm sure you're gonna have to give me lots to think about in the afternoon. I'm getting ready for it. But we have to do it. If we don't do it and prioritize the equity piece first.
But it also asks for a dynamic perspective where we not just look at things like in one point in time, but also like if we have included like a diverse set of people, but then a lot of people fall out and we don't look into dropouts, which often happens, then we're also not working on equity at all.
Exactly. You have things like TikTok. We've running this TikTok study. It's been a joke, but it's not actually a joke anymore because it's actually really good science. Because I realized there's like 100 billion hashtag mental health things on TikTok. They're not talking about it in a focus group. They're talking about it on TikTok right now. And they're talking about it in like there's different ways of gathering information and finding out what people need. Like, you know, climate change. Like, why are we not all quitting our jobs and just studying climate change right now? Because that's what everybody wants to talk about. And so there's just different ways of gathering information of what's important to people. You don't need to have everyone in the room, but you need to look at like getting the right people in the room, thinking who you don't have in the room, and then finding other ways in which they're showing up and sharing information. So thank you. I know it's lunchtime.
Good, let's thank you again.